your database of patients?
Me?
Yep.
Um, Probably about 500.
Okay. So another nice thing, how often do you communicate with them?
Not enough.
Okay. So for instance, you craft, and I can help you craft a couple of nice messages for them. And have you ever done a workshop?
Not in a long time.
Okay. So for instance, let's say you're going to do a neuropathy workshop. The message you're going to send to those people in your database is not, have you been suffering with numbness or tingling in your feet, your hands? No, because the reason they're in your database, you may have helped their shoulder, or you may have helped them with headaches or something else. The message you're going to send them is, who do you know who's been complaining about numbness or tingling in their feet or hands? You know, those are classic symptoms of neuropathy. On August 24th, we're going to be doing a special workshop showing the state-of-the-art treatment protocol for this difficult condition. That's kind of how you do it to that internal market.
Great. Thank you.
You you can also just search under EMR. If you can search under diagnoses, I don't know if you can do that on your EMR.
I don't have an EMR.
All right, so then right in that brain. Good luck with that.
Mary Jane, can you hear me?
Yeah, finally I got my sound working.
Okay.
Okay, I got a gal coming in today. She's 90 years old. She had a lesion removed from her lower leg a few months ago, and she had it removed by radiation because she had a heart condition. Well, when they removed it, it wasn't too bad, but she went back for treatment, and the gal was digging around at it and stirred things up, and it made it worse. And since then, every time she goes in for wound care, it's worse. At first, it was getting better, and then they stirred it up. They try and debris it without her being under anesthesia, which is crazy. And it doesn't even look like it's really debris very well. So it looks kind of rough. But every again, she's in such pain after the last treatment they did on her. They want to double her gabapentin. So my question is, I've done the Stimpod on her, and at the beginning it was very successful. After they've stirred it up, she comes in with a dressing wrapped around it, almost up to her knee. I've kind of taken part of it off. I'm not afraid to take it off because my background is nursing, and from what you mentioned yesterday, Stan, and she said it would be fine with me taking it off if I need to. So my question is, what do I need to do to help her be more comfortable and being, where do I need to, before I was just trying to do the pathway through the wound, like around that area. And now I'm wondering, what should I do?
And
I
Jeremiah,
mean,
I just sent you and Kieran the picture of the lady's leg.
She's not, but she's very healthy otherwise. I mean, she looks really good. They were even talking about taking her leg off. Now, I had a guy several months ago who had got a bite in Africa, and his leg in 3 days got gangrene, and they debrided his whole foot, but they debrided it down a half inch. It was very clean. And when they started doing the treatments on him, he healed really quickly. And he owned a stim pod. So, but this gal, I mean, I think it just looks really not very cleaned up. So they're talking about taking her to surgery and cleaning it up.
so you could approach it two different ways. You can go all around the lesion itself, and
Okay.
then you could just kind of look at your essential anatomy app and just figure out whatever nerve is going right through the middle of that lesion.
Okay.
And that's how I would approach it. And then just put the ground pad distal to whatever nerve that you're treating from above.
Okay. Like put it on the top of her toes, probably.
You could even put it down this. You could even put it just beyond where
Where the
lesion
wound is?
is.
Okay.
Yeah,
Okay.
and just try to connect A and B.
Okay. She's going to come in a little bit. She's on her way. Yeah. Well, that's great. I'm happy. I'm happy because I
You
know we
doing
can help her.
Good.
you doing vagal stim with her?
Yes.
You
Yes.
doing so she's one because of what's going on pain wise. You doing just left side or have you done anything right side?
I've just done the left side
Do about 4 or 5 minutes on the right side. Do
with
it,
vagal stim. Yeah.
do it first, and then you can end on the left just so you make sure you get her system calmed back down.
Okay. Great.
And
I have
then
a
other than that,
question.
do you have any access to any red light, laser, anything else?
I have a red light. I have the Wellness Pro machine. I have other light technology. I have the
So
Resumex. Yeah.
strongest red light that you have. Have you done any red light or LED to that leg or to the wound?
No.
Do
She,
there
she
you
always has it.
that's
She always had it wrapped, so I didn't unwrap it, but I'm going to today. Yeah.
Yeah, so knowing that in the wound world because it's antiviral, antimicrobial, and calming that tissue level irritation down is going to be one of the biggest things that you can do if they went in and stirred all that up. And pain's going to increase anyway, so you also need to educate her that as that wound starts to heal, just like a first, second, third degree burn, it's probably going to feel pretty nasty for a bit, and that's okay. So as long as since you've done wound care, you know that the rest of the healing is okay. Pain might increase now if she's getting some healing going on because we get that in the severe diabetics as well. So your point of treating her is obviously you want her comfortable, but it could also be different now and you're still going in the right direction, even if she is getting some discomfort, depending upon the stage of where that wound is going, because the healing that's going on and the process of that, right?
Right.
So
So,
that's why you always have to just be aware of what we're treating and understand with what it is instead of just hoping, because Stimpod and everything works when anatomy and the person is either clear from normal or far from, and that gap in between, we have to be able to reassure people that you might have some shitty days, but it still doesn't mean we're not going in the right direction.
yeah, yeah. It's just that she was, she's like I said, she's good, and then she gets really stirred up, and she just gets much
Yeah.
worse, especially when they talk about doubling or gabapentin or
Well,
doing more.
and she should, but if she's that age and you've got a distal wound, we know the likelihood of that healing if she's not getting red light or other decent nutrition. I mean, that's going to be the big thing. Is also ask her too, what's her protein intake like? I mean, to be able to heal tissue in any of that, if her protein and caloric intake isn't high enough and that's her age, it's also going to add to it as well.
Yeah. I also have her on, I do nutrition, so I have her on Biotics Nutrition for nerves and for the staff, for her
Sure,
immune system. So a combination of things to,
sure, but where's she at caloric wise? So you need to make sure she's also eating more than what she normally would
okay,
on top of that to heal.
okay. All right. Perfect.
Yep.
Great. Let us know what happens, Mary Jane.
Yeah, I will. Thank you.
Right.
I'll be cutting out soon. She'll be here.
Okay. All right, Matt, did you have a question?
Yeah, my question's for either Jeremiah or Dr. Collins or both. So we're trying to do, we've been treating a lot of people with neuropathy here. And so the protocol we've been doing is fibular, head, tibial nerve, and then sometimes we'll do the deep fib between the toes, and then the vagal in the left ear. Now, do you guys recommend? I've been doing pad on the same side. Do you recommend pad going to the other side or vagal? I heard Jeremiah say vagal stim to the right side, which I have never done. What's your guys' thoughts, if you don't mind me asking?
JJ, you can go.
So rule of thumb is follow the standard protocol. Those other things, that's stuff, when people bring it up for this call just because they're struggling with it. But 98% of the time, stick with protocol. Pad for vagal stim. Pad can go virtually anywhere you want within reason because you're stimming that side. So if you're upper trap, shoulder, arm, wherever you want, you can have that for the vagal stim. Sometimes what you'll find if you're what are you noticing when you treat people neuropathy wise if you're doing common peroneal and posterior tib.
So we do get some relief out of some, but we do have an individual who he got no relief, and we treated him for 6 weeks, and then he rented our machine for a month. Um,
Okay, so
that's a tough one.
So,
so
What's
but
that, Jeremiah?
he's probably more of an anomaly. Like, what's his origin of his neuropathy? That's the question.
So that's so we talked about that. So when he came in, he has a Parkinson diagnosis as well.
yeah.
And
So
so he
the other
also
thing,
has a lot of edema in the legs. So sometimes it's
yeah,
hard getting a twitch.
correct. So the challenge with that, if that's not managed, I've had some people I've truly just sent them out for lymphatic massage, and until you get that addressed, you're fighting a battle you're not going to win. The other thing would be if you aren't seeing changes within a week to 2 weeks at any interval, then you either need to change something up when you're on these calls, whatever. It doesn't matter. It's not that anything's done wrong, but you're not going to need 6 weeks there and then a home unit before you see any change. So if that edema is the issue, then you won't win that battle. And what I tell people, if you grab something out of the oven and don't have an oven mitt, it's hot right away, right? As you add buffer to that, it blunts that. Well, the reason Stimpod works with radio frequency is because it's very specific to the nerve. If there's too much fluid or lymphedema in a region, you're not going to get down to that level, and it makes it dispersive, and its ability to work isn't going to happen on top of a Parkinson's diagnosis. So there's nothing wrong with that. Some of your Parkinson's people will be amazing, but we always have to appreciate that if the anatomy's off enough, or you have symptoms of something, just like the last one, a wound or a ton of lymphedema, and you can't get down to tissue, then your dosage isn't going to be high enough to get the result that you want. And if you don't get sensory and motor in most of the lower extremity issues or upper extremity, then your ability to be confident to know that you're getting enough results is what's going to happen. And that's just his current physiology. Doesn't mean that the setup you did wasn't right. Doesn't mean you need to go chase any other areas. It's purely just the fact that he has too much fluid in between where you need to get that it's going to pick it up and disperse it, just like red light or anything else would. And so radio frequencies, Stimpod's beauty is it's able to be specific if you can get it there. If you can't, that's why it doesn't work if you try to hook this up to 2 electrode pads. Well, with enough lymphedema, that's all you've got is you've essentially turned it into 2 electrode pads, and the likelihood of getting enough relief isn't going to work.
Would
And
you
also,
recommend pairing it with like red light or any like shockwave or anything?
100%. Go ahead, Karen.
but like if you were treating at the ankle and you're trying to do posterior tibial, you're not going to be able to do that with all the edema.
Correct.
So you want to go back up to the top of the knee and go from behind the knee down.
Which is
try
why I
to-
say if you've got that much on somebody like him that's not moving well, then you also have to start partnering out, because you're going to get these types of diagnoses. And you can try higher, like Kieran's saying, but if you try that a couple times, you don't get it, then you got to be honest with them and say, we need to get this edema managed. And then here's the next step, because then you can always go proximal, but if you do that for 2-3 times and you don't get results, then you have to manage the physiology that's in front of you.
Okay. Now, I did have a question along with for Dr. Collins, because I have tried doing behind the knee, but I wasn't getting a twitch, so I must not have been directly on the nerve, correct?
No, that's not. If they can feel it running down their leg, if they can feel it running down, that's fine, because you
Okay.
don't know the amount of degeneration that's happening. So like motor's going to leave before sensory.
Yep.
So that not necessary. I've treated people where they couldn't feel anything, and they couldn't feel it. They didn't. There was 0 motor, and they got relief amazingly.
Mm-hmm.
And I was like, "That's amazing." They couldn't feel anything, but they were on dialysis, so they had a huge amount of edema, and it was rather shocking. But they did get some relief.
All right. Thank you. I do have one more thing. This is Hannah. She's our new PT, so she's going to be a part of the community as well.
Great.
Hello.
Fantastic.
Great. Have her go to my YouTube in yesterday's email so she can subscribe. And we are now posting, so the replay of this call will be on the new YouTube channel. Last week's call, that's where we posted it. And so now we're going to start posting everything to the YouTube channel.
Oh, great. That's great.
Good. Hey,
Thank you,
Nicole,
guys.
what's happening in Newport?
We're having fun with the Stimpod for sure.
What happened with your trigeminal lady?
I went a different direction with her treatment because she was super afraid to do anything electrical. So I just did something different. So I'm going to be warming her up to that this is going to be a good idea. I think I'll be able to do it on Saturday. With my Bell's palsy person, I think we had a good result. I treated the way it was recommended. And by the end, like at the beginning of the treatment, her symptoms are on the left. There was no pulse, but she could feel, she had sensory, she could feel what was going on. Then I did the right side, and then I came back and I did 3 minutes on the left, really high, like was recommended. And then I did the right, and then I went back and did 2 minutes on the left, and we got a pulse when I came back. So I think that was good. She had a little bit improvement of being able to close her eye and a little bit better ability to purse her lips. I also treated her palate for 1 minute.
Nice.
Palate for 1 minute. I wasn't sure if I should do more or not because I'd already done quite a bit. So I just did 1 minute.
Yeah.
But then the other, I had a question about a sciatic presentation that also is presenting with what seems like a Morton's neuroma kind of combo. But I'm open to any feedback about the thing that I did with the palate. Would you guys have done longer on the palate or stuck with what I did?
I mean, I generally do 3 minutes everywhere.
Okay.
But that's me. Some people do way shorter than that.
Okay.
And it was Bell's palsy. So why did you put it on her palate?
Because when I tested her palate, it doesn't move when she goes off.
But it wasn't perfect. It works great in the mouth, though.
What's that?
It works beautifully in the mouth.
Okay.
Yeah.
Yeah. So you would do 3 minutes on each spot then.
Yeah,
Yeah.
you sure can. So know that there's other stuff that's less. Always trust the first time you're doing this with somebody, you're assessing while you're treating. So that way you get kind of out of the mindset of also thinking, am I doing not enough or whatever? Some of this is going to be patient basis, right? So you can always go up. Underdosing when you have these types of things usually isn't the problem, in the sense that you still delivered a ton of energy to her body, right? Or to this patient's body. And so at the end of it, agreed, as you get more comfortable, then yeah, you can be doing 3 minutes or 4 minutes like Kieran does, but he's treated 10,000 people with it or whatever the heck it's been with helping out. So sometimes those things happen and just intuitively in treating, it's great. But just always go back and remember you're assessing every time you put this on someone. And so it's also what is their feedback, right? Because if you go for 3 minutes and you go, shoot, now they had a problem, was that too much? You're going to be chasing yourself instead of just trusting and going, you know what, clinically, did it for a minute, document it, and then next time we can always go up or down.
Okay. All right. Sounds good.
In reference to the neuroma, like those are two separate things, and the sciatica.
Yeah.
The neuroma is super easy. All you're going to do is put it directly on the top and the bottom of the foot. You can switch the ground pad up and down and just put it on there. And that provides amazing relief for people. It all depends, like the half-life depends upon the patient, but it's usually a couple weeks.
Okay. So
And
just to be clear, so if I'm treating the neuroma, I could put the pad either on the top of the foot or the bottom.
And then you'll flip it and do for the next part of treatment, you'll flip it again.
yeah, so you're going to do the pen on the top, ground pad underneath the foot, and then flip it back. So you can do like 5 minutes each, and then that's going to immediately provide her relief. And then just do the sciatica. You could do it at the ankle. You could do it wherever you feel like doing it.
Okay. So if I'm treating her for the sciatic, I've been putting the pad on the bottom of the foot, and then I'm treating the common peroneal, can you shut the door? And the deep tibial with the pad on the bottom of the foot. And then, so that's what I've been doing. And it hasn't given her much relief for the neuroma. So you're saying
It's not going to give her
after
any
that,
relief.
what's that?
Yeah. It's not going to give her any relief for the neuroma. You got to put it on the neuroma itself.
Okay, yeah. I mean, she's like, oh, I feel like my whole foot feels better, but I still have pain, right there. So if I put the pad, so then after I do the sciatic, do I put the pad on the top of the foot and put the probe right on the neuroma?
What you could do is leave the pad so you're not changing it. Treat on top of the foot where the neuroma is, and then flip the pad on the top of the foot so you're only moving the pad once, and then treat the bottom of the foot.
I see. And you're saying treat it for 5 minutes on the top and 5 minutes on the bottom?
You can.
If you
as
can,
long
yep.
as you don't. Yeah. Neuromas are great. Like, they work beautifully, but think of those as two totally separate things.
So
Yes,
they are.
You were saying earlier, like 3 minutes, most people use 3 minutes. And then now you're saying 5 minutes for the neuroma.
No, you can. So like the neuroma thing is a little bit different to me because I don't intend on treating that for weeks.
Okay.
Like when I use Stimpod for 3 minutes, it's literally like I'm using it like a magic eraser.
Okay.
And I'm just going to test it afterwards. Generally, when I treat nerves for 5. Some people will treat it for 3, but I treat it for 5 unless I have a lot of nerves to treat. If I have a lot of nerves to treat, I'm going to treat it for 3. So it's really just a time-sensitive thing.
Uh-huh.
You can treat that neuroma for 3 minutes on each side, and she's going to feel great anyway, because she's really going to get at least 6 minutes of treatment to that neuroma on the top and the bottom.
Okay.
And realize the other is when you're up on the face, and the tolerance of that as you get closer to the head with stimuli, it's been showing it just doesn't always need as much.
Okay.
So that's the other difference of comparing the two. It's, like chin up, if you're on the face, a lot of those things for each spot, they just don't need as much. Doesn't mean you can't treat it longer, but anything more distal you go for those spots in the feet. There's podiatrists all over that once they start figuring that out, they're blown away because it completely gets rid of all the symptoms of some of those things with neuromas or even scarring post-neuroma in a foot that people have had for 3 years, and it'll be gone for months after even one treatment.
Wow. I'm excited to try it on her neuroma.
Yeah.
Ooh. All right.
There are tons, and you know that there are tons and tons of women with neuromas from shoes.
Oh, yeah. Yeah. So are you guys saying that, so for the face, it would be 3 minutes per spot, just because the face is showing that it maybe doesn't need as much time, and you could consider doing more, but start with 2-3 minutes per spot.
Yeah, like on the face for Bell's palsy, you're going to be treating like five spots at least, right? If not 6. So that's a time sensitive thing. You don't want to do 5 minutes on each because you're going to be there for 30 minutes on the face. So just shorten that up a little bit based upon the number of nerves you're treating. And all the nerves in the face are really superficial. And it's the same thing. Like, I don't treat, generally, when I'm treating an entire carpal tunnel, I'm only going to do 3 minutes on each nerve. That's it. Because the nerves are so superficial and they respond so quickly.
So for carpal tunnel, are you doing it right at the wrist?
So for carpal tunnel, I'm doing radial underneath the thenar pad and median at the middle finger, and then right above the pisiform for ulnar.
And for medial at the middle finger, you're saying like down at the wrist?
Yeah.
Or? Okay.
Yep.
Yeah, no, at the wrist. And then I tell them, I want you to feel this in your middle finger and half your ring finger. And then every time you put it on ulnar, you're going to see this gross fasciculation in the entire hand.
Okay. And the pad, where does the pad go for that?
I usually just put it on the opposite. I put it on the opposite wrist, honestly. That's what I do. You can put it anywhere on the other side.
Okay. Gotcha. So for the bells, I came away, I have to go back and relook at the call on the video from what you told me last time. But for the Bell's palsy, I came away from that thinking it was just treat right where it's superficial by the ear for 3 minutes, and then the palate. And
no. So for Bell's, if it's a true Bell's, you have to look at whatever their deficits are. right? And you address that first. But if it's their eye, it's the medial eyebrow, it's the corner of the eye, and right below the lacrimal duct.
Okay.
And then right above your cheekbone goes into your nose.
Mhm.
And then, like, right parallel to your mouth, it's going to go into your upper lip. And then you go to the angle of the mandible or anywhere along the mandible, and you're going to see that going right down there. If you try to do trigeminal, like sometimes people, like I've had, trigeminal offers a lot of relief if they're having any pain with the bells. Trigeminal is great. But elsewise, I'm not messing with trigeminal unless that's a component of that Bell's palsy.
Yeah.
Gotcha. All right. Now I remember you saying that. Okay. So probably get an even better result doing all of those points next time. All right.
I have a question
You'll
about,
get great. You'll go on.
do you ever do some hands-on treatment at the same time that you're doing Stimpod, where they're holding it and then you're doing some manual treatment at the same time? I was trying that the other day and it seemed to work well, like with vagal stem, like doing like a manual traction or cranial release. But I was just curious at what results you guys have seen with that.
I haven't done anything like that. The only things that I've done, I've had people go through range of motions, like with their shoulder. And like I had a PA who was treating with me for his shoulder, and he loved to do the range of motion, move it all over the place doing the brachial plexus. But you can obviously do that. And if they're in a relaxed state, if you're doing like cranial therapy, that'd be really smart. And I just haven't done it. I should have. I actually treated a woman with TMJ and migraines yesterday, and I did do it, but I did them all separate. So we did her eye, and then we did we did trigeminal with the TMJ, and then I did like cranial stuff to her, and she was happy first visit.
Okay, and when you do range of motion with it, you're just doing range of motion distally, like so that it doesn't affect get them getting off the nerve. Is that how you do it typically?
No, I mean, like, so if you're like, the only time I've really done it is on brachial plexus, and they're literally holding the pen here, the pads on their finger, and they're just moving their arm in different directions just
Okay.
to, but that's interesting it's an interesting idea doing vagal stim and whatever manual therapies you're going to do.
I've been doing vagal stim while they're on cervical traction, and that's worked well. And I'm also doing as much as I can with the Stimpod. I'll prop it. Like when I'm doing sciatic stuff, I prop it on a towel for all the different points, and then I'll be doing other places on their body. They're just laying on their back, and I've got it just propped. So definitely, I'm seeing good results doing that.
Yeah, I've been propping it also, and it's working well. Yeah.
That's what I do. Any headache, migraine, anything cervical, while if they can hold it and treat it and relax, or if you can prop it, there's no reason not to be working on them, because it's going to stay in place. A little bit different if you're doing, thoracic stuff, but if you can get the lower extremity and get it propped, there's no reason why you can't be doing anything lumbar and sideline. I get that because I get to needle everything, so it's one of those that even when that's on, sometimes I'm doing soft tissue work above or below with wherever it's at. So there's no reason why you can't. Obviously, if they're getting enough of a contraction somewhere, it could be counterproductive. But cervical wise, they'll absolutely love you for it. Or it'd be the same thing lumbar, not to set some things up and do some isolated traction or whatever you want while you've got that going on, or even a knee or a shoulder, add some traction to it. There's no reason not to.
Okay, great. Thanks.
Yep.
Tinnitus and
Good
hearing
question,
loss.
Kim.
I do manual too. They love it because it's adds to the relaxation of it. But I have a lady coming in with sensory neural hearing loss and tinnitus. She's been to ENT and had MRI and been given 3 steroid injections and now is being offered a cochlear implant. So I'm not sure if we can help with hearing loss, but I know we've talked about it before, but if you could go over tinnitus suggestions, that would be great. She comes to see me Monday for a first session. But hearing loss and she's got some numbness on her ear and pretty bad tinnitus. So she's looking to at least get relief with the tinnitus.
So, this isn't my formula, but this is a PT who's a very smart guy in North Carolina. His name is Shiva. He has been doing it he gave me his formula for tinnitus. So it's vagal stim, it's tragus, it's trigeminal, and mastoid. So he's only doing a couple minutes at each point. I tried it at a conference, didn't work. I don't know what to tell you. I don't have super confidence in doing it. It's not going to hurt him. I've had positive results. So again, what this guy attests that is fantastic for this. So it's vagus in the ear, tragus, trigeminal, and mastoid.
Okay, so vagus stim in the symbicanta, and then tragus,
Yes.
trigeminal, and mastoid. Okay.
Correct. And so it's like 2 minutes on each.
Okay.
I hope it works. That's it.
Okay.
With the trigeminal, do you do like 3 branches of it, or just pick one?
No, you're gonna try to get all 3.
Okay.
Like when you're doing trigeminal, you're gonna move it around until you get at least 2. And if it's like when I think if I have 2, I'm really getting 3 anyway. But you just have to move it around a little bit.
Okay. Can you elaborate on the vagal stim to the right ear when you would do that?
So I've only done that. I did that on this nun that I treated for a second time this week. Just because I was trying to do as much vagal stim on this woman as I could. She had this throat issue where she would cough starting at 12 o'clock and then she couldn't speak by 6. And she's like, I'm cured. There's like nothing. She like texted me. I put it on Facebook and it was the most responded to thing. 25,000 people saw it. I was like shocked.
Wow.
And she, so I did vagal stim in each ear. And then the first time I did anterior cervical vagal stim along the neck, also bilaterally on her, just to innervate that vagus on both sides to try to make it work, and it worked. So I was just trying to cover my ass as much as possible and give her as much therapy as it could, and then it worked.
And then remember down in Houston, that guy who had like the 14 back surgeries, we did vagal stim. He really responded well. Lefty, remember him?
Yeah, that guy. Yeah, that guy was. But that was so. This was a guy who was probably 32 years old, and he had like already 4 cervical spine surgeries. He had 2 discs, like those artificial discs, installed, and he still came in with a 10 out of 10.
Wow.
And I'm like, dude, this is like 100% in your head and it's real. But he got relief when we did vagal stim on both sides. So the traditional philosophy on not doing the right side, is SA and AV node in the heart. There's less cardiac involvement with vagal stim, with left-sided vagal stim versus right. With this guy, he didn't care. He was ready to like jump off a bridge. So I'm like, all right, dude, we'll just do this on you just to see how much stimulation we can get in. And that gave him relief.
When
So
you've done both sides for vagal stim, how long do you do each side?
with the nun, I did 3 minutes on 2 parts on each side.
And
But
you
I was
finished with the left, right? You finished with the
What
left.
was that?
You finished with the left side, right?
I honestly don't even know what I finished with.
Okay.
I would if you're setting it up, just because we know there's a chance with their system. So for all of you that are on this call, if you're going to do that, do it for just a little bit. If you're going to be doing it on the right for 2-3 minutes, and then finish on the left, because you get a stronger result of supporting their system. And then it's also going to give you some time to monitor them while you're treating them and seeing what's going on. Completely safe to do it, but it's one of those things. It's a CYA, so why not? Right? So if you're going to treat that, go ahead and do it, and then cover the other side and then see what happens to your system. Because even if there was going to be some involvement, supporting it on the other side should help you, kind of dampen the system with between sympathetic loads. So why not? And then you just have a basic.
I 100% agree with you. Do the right and then do the left. I didn't even think about it.
Do you guys
But
you only do the right if it's like somebody who's just off the charts, sympathetic overdrive? And
Yeah,
then do it?
like that was just like he was just complaining like literally of everything going on in his neck. And like I literally had to like talk him off the ledge to try to get him just to do this. And he got relief, but it might have been just like it might have been part of the conversation. You know what I mean? Like I'm giving him hope and optimism, and then we're doing the vagal stim. He's just chilling out a little bit for the first time, and he's not just super, super sympathetic that he's screwed. But he's like looking for that third artificial disc, and I'm like, you're out of your mind. Like you already did it twice and it didn't work.
Yeah. Maybe this time.
Yeah, let's hope.
Julian, you got anything going on?
Sure. Young gal, or she's
your
young
camera
to
just
me.
went off for some reason.
Can you still hear me though?
We can hear you.
Okay. This young gal, she's 32, 33. She's had L5S1 fusion since she was 17 years old. Kind of chronic pain. They're telling her that the only thing is to do another fusion. But some of them tell her to do another fusion. Some of them tell her not to do another fusion. She's in pretty constant pain, mostly in the low back region, wraps around into the front of the hips, a little bit of sciatica, kind of posterior, hamstrings bilateral. It changes back and forth. What's the best approach? Pad placement. I saw her once. I treated her once. She said she felt a little bit better. She's coming back today, so I'll see how she did. I did the pad at the S2, 3, and I did kind of SI and then sciatic. I just did both sides, and then I did the common peroneal. That's all I did with her last time.
I'd be concerned about the fusion. So like you want to get some like whoever whatever neurosurgeons or surgeons she's consulting with, you want to see if they took the flexion extensions to see if there's any translation.
They
flexion
did.
extension.
Yeah, they did, and she's got a little bit of translation.
Yeah.
So if you're just trying to help the symptoms, like is it one-sided more than the other? Is it a herniation? Is it just the fusion? Is it just the spondylo that she has?
Yeah, no significant herniation. They just think it's the spondylo. So it's I'm just trying to give her some relief, type of thing. I don't know. You guys are the experts.
Is it more axial or not axial?
Not axial.
JJ, did you hear the pain description? Because I didn't catch it all.
Yeah. Any spine I've ever treated, if they have instability or movement and they've had a fusion, which is what you said she's got, right? She's got translation.
Yeah, she's got I think they said like 2 millimeters of translation.
Yeah. And so the problem I've had with anybody that has that, until that's fixed, you'll treat them and whatever else, and it's going to be in a spiral pattern. So if she gets enough relief, then it could be somebody, if they want to wait, because I don't doubt that you don't want to have another fusion. But if something happened and that's what's going on, I've even done needling, done a ton of Stimpod on people, soft wave, any of them if they have that instability. And sometimes what I have noticed more than not is as you get rid of some of the muscle guarding, then symptoms typically even increase more. And so not necessarily going to happen with her, but that's the concern. So if she's got an instability and she had a fusion and stuff before, unfortunately for that, until that's fixed, she's going to continue almost always having symptoms. I haven't ever had great relief with anybody having that. The others that got it fixed, then afterwards,
Sure.
all the carpal tunnel went away that they had a surgery for, and I told them not to get it done. Shoulder stuff cleaned up. So at the end of the day, you know, your pathway that you treat is probably right. Whether or not you're really going to get much in the SI and sacrum, if the pad is there and you're treating it because it's deeper, unless they're really thin, probably not. So you could treat other stuff in the legs, even if you leave the pad on the sacrum, or just go to the normal lumbar protocol, because you might get some overlap. And even though she thinks she's got symptoms where they're at now, that could help you kind of assess some things to let the doc know that, hey, even though this translation's going on, is there anything else going on sensory and motor? Which doesn't mean she needs surgery, but could give her and you some input as to whether or not you're really going to make any significance on that.
Okay. Yeah, we've done shockwave on her before. She did not tolerate that well
No,
at all.
usually, yep.
Yeah, laser, she does well with laser, but yeah.
You could
Before,
also talk her into vagal stim, because I've treated failed back surgery people with vagal stim. If you educate them well enough at how it's going to work and just try to calm them down.
I tried, I forgot. I did do that with her last time.
Yep.
Like, if you can get her to come in and just talk about the benefits and really educate her on the vagal stim, it's a possibility to offer a lot of relief.
No.
It just takes a little bit of time. Like, if I'm basing it on vagal stim, I'll be like, I want to see you. I would expect to see some results after 4 visits. And we're going to see you twice a week for 2 weeks. And then we want you to try to start breathing regardless of whatever condition you are. Like, breathe before you get out of bed. Like, I literally tell my patients, take 25 breaths before you get out of bed, and then take 25 breaths before you go to sleep. So we're going to start the day calm. We're going to end the day calm. Because she's going to be completely sympathetic as a result of the pain and the depression that she's experiencing and the anxiety. So it's like a combo factor of a bunch of crap.
Yeah, she's been dealing with this for a long time too. So okay, I'll try that for her. Awesome. And I have one guy. He had bilateral total knee replacements. One of them did great. The other one is continuing to cause him pain. He's also got bilateral neuropathy. Fit guy. I mean, he cycles 60 miles a week. Some swelling they can't get rid of in his right lower leg, which is the side where his knee's still giving him pain. I treated it, common peroneal tib. Would you do anything different?
If he's getting relief, so I mean, are you treating the knee replacement?
As far as therapy or with Stimpod?
Yeah. I mean, are you doing anything? If you're doing Stimpod and you're gonna try to stabilize his knee first, and then you could work on whatever you want to work on.
Yeah,
so
we've
it's like
worked on
whatever
stability.
the issue.
Yeah, his knees are stable. We've worked on his knees. He's solid, like I said. He's cycling all the time. He's got good strength in there. They can't figure out why he's having the pain. So I don't know if it's almost kind of turning into crips or something in there. But yeah. So I didn't treat the knee any differently. Would you also do something different for the knee other than just kind of the neuropathy stuff?
No, I mean, you can treat the saphenous. You can treat any point of pain in his knee.
Okay.
If you want to address the knee.
With a pad in the same place at the foot?
No. So when I'm treating saphenous, I just look at your anatomy. It's like right below the tibial plateau. So you're going to treat on the medial quad, like about 2 inches superior and medial to the top of the patella. And then you're going to put the ground pad just lateral to the tibial prominence. And they're going to feel that like fish hook running of that nerve.
Okay.
And then have you tried the Liberty patch with him as well?
I have not.
Put the Liberty patch on.
Sounds good.
All right, guys, I got to run. We will do this again next week. And again, this replay is going to go up on YouTube. It should get up there sometime later on tonight. See you guys
All right.
next week.
Thank you.
guys.
Thanks, everybody.
Thank you.
Thanks.